हेलो डॉक्टर आकाश। गुड इवनिंग।
गुड
कैसे
इवनिंग
सर?
डॉक्टर
ठीक है सर,
आकाश।
ठीक है। ठीक है
हाँ,
सर।
आपकी मीटिंग खत्म हो गई जिस पर एंगेज थे?
हाँ हाँ, हो गई आज। तो
हो
हमारी
गई।
2 दिन की लिपिडोलॉजी की मास्टर क्लास थी, तो
अच्छा
काफी अच्छी
अच्छा।
गई। 100 जने रजिस्टर के उन्होंने अटेंड किया, कल और आज 2 दिन चला।
हम्म,
डॉक्टर आकाश अपने पीछे की लाइट ऑफ करा दीजिए।
हाँ।
हाँ करेक्ट है वो।
इस-
गुड
और
इवनिंग
सर,
सर।
गुड इवनिंग डॉक्टर अभिमानी।
गुड इवनिंग
गुड
सर। गुड
इवनिंग
इवनिंग
सर, गुड
सर।
इवनिंग।
डॉक्टर सर को प्रणाम।
गुड इवनिंग
प्रणाम
सर, गुड
केदार
इवनिंग।
साहब।
गुड इवनिंग सर।
गुड
सर
गुड
प्रणाम।
इवनिंग सर।
गुड इवनिंग। नदको राय तो बड़े यंग लग रहा है।
गुड इवनिंग सर।
ठीक है, आपका चेहरा अच्छे से दिख रहा है। तो पीछे से वैसे
धन्यवाद।
अच्छा लग रहा था। इट वाज लुकिंग लाइक एन ऑरा फ्रॉम द बैक। आजकल ऑरा डांस भी बड़ा पॉपुलर हुआ है ना।
डॉक्टर आकाश बैकग्राउंड में लाइट लगाते हैं।
अरे नहीं नहीं, वो तो अभी
तो हम लोग जब उसमें थे, रेडियोलॉजी वाले पढ़ाते थे ना, हेलो साइन।
हाँ हेलो सही नहीं,
हेलो
करेक्ट।
सर।
यू रिमेंबर दैट? हेलो साइन।
यस यस।
चलो सही ना। अभिषेक। अभिषेक लगता है ज्वाइन नहीं किया अभी।
अभी
Yeah,
अभिषेक इज
क्या?
देयर। अभिषेक इज देयर, अभिषेक
हाँ, he
है।
has joined. He has joined.
फिरमानी साहब, खांसी बड़ी आ रही है।
हैं?
खांस रहे हैं बहुत।
कहाँ खास रहे हैं?
और क्या।
एक बार भी नहीं खासे।
सर प्रणाम, सबको प्रणाम।
हाँ 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 अभिषेक।
अभिषेक आ गया।
सब ठीक है अभिषेक?
यस सर, एवरीथिंग इज फाइन।
गुड
स्टार्ट कर
गुड।
दें?
नाइस टू सी डॉक्टर अभिषेक, बहुत दिन के बाद।
थैंक यू सर।
वेलकम अभिषेक।
सर प्रणाम, सबको प्रणाम।
प्रणाम प्रणाम प्रणाम। वेलकम नीरज।
नमस्ते सर।
नमस्कार।
क्या हाल है नीरज, ठीक है?
ठीक है सर।
हाँ डॉक्टर नीरज।
नमस्ते नमस्ते सर।
नमस्ते नमस्ते, खुश रहिए, बहुत दिन के बाद।
नीरज इज डूइंग
मृत्युंजय ने
वेरी।
मृत्युंजय को फ्लू हुआ है, अब ज्वाइन कर सकती नहीं, सर्दी खांसी
ओह,
बुखार।
अच्छा अच्छा।
अच्छा।
मैं
आज कब
ज्वाइन,
चला
मेरा ज्वाइन, उनको फीवर था।
ओह ओह, आपका तबीयत ठीक है ना सर?
हम ठीक है डॉक्टर पंडा, एकदम ठीक है।
बहुत अच्छा बहुत अच्छा।
सर तो टी
टाइम तो
शर्ट
हो गया
में,
है,
टी शर्ट में
स्टार्ट
स्मार्ट हो
कर दे
गया।
सर।
ऐसा है ना
प्रणाम
डॉक्टर
सर।
जगदीशा की, जब ओल्ड एज होता है तो यंग लगने के लिए कुछ ना कुछ नया चीज करना पड़ता है।
करेक्ट
हाँ
प्रणाम
हाँ।
प्रणाम।
करेक्ट
यंग तो
करेक्ट।
यंग रहता ही है, जो ओल्ड होता है उसको कुछ ना कुछ नया करना पड़ता है।
सर सर
वेलकम डॉक्टर झा।
हाँ प्रणाम सर।
प्रणाम।
डॉक्टर सुधीर जा।
हाँ जी,
हेलो
प्रणाम।
बस। हेलो बस।
राय सर प्रणाम।
प्रणाम प्रणाम झा जी।
प्रणाम।
और मधुकर राय जी फिर नहीं दिखाई दे रहे हैं?
अरे
हाँ
यही है
बिल्कुल दिखाई दे रहे हैं
दिखा
भाई।
दिखा दिखा
अच्छा, हाँ
दिखा।
हाँ, अरे
सर
अरे
बैग
हाँ हाँ,
बैकग्राउंड
सबसे
रेड है, बैकग्राउंड रेड
सब
रॉयल
है।
अपीयरेंस।
सबसे सबसे ज्यादा सूट वही लग रहा है
हाँ
इस समय।
हाँ
सबसे
असली अपीयरेंस।
दादी सबसे हैंडसम मैन आपको नहीं दिख रहा तो क्या बोला
हाँ
जाए?
हाँ, नहीं नहीं।
आप थोड़ा
मिस
नीचे
फॉर ए
होके
वाइफ।
बैठे हुए हैं, आधा ही मुंह दिख रहा था, अब ऊपर आइए।
लेकिन एक बात सर, प्रोफेसर राय को देखने से, मधुकर राय को, हमको वहाँ बनारस का सब चीज उनका साइंटिफिक जो था, इट वाज सच एन एक्सेलेंट प्रोग्राम। आई वाज रिमाइंडेड ऑफ दोस 3 गोल्डन डेज।
हाँ, एक्सेलेंट एक्सेलेंट टाइम।
एक्सेलेंट।
वेन्यू भी अच्छा था, बनारस का वेन्यू भी, जो
हाँ
हाँ, मॉडरेट साइज हॉल्स और सब कुछ था।
सब कुछ सर
खड़े हुए
वेल
थे।
अरेंज,
हाँ,
बहुत बढ़िया,
बहुत बढ़िया।
बहुत बढ़िया।
कॉलेज डेज याद आ गया था अपना।
एक बार सर,
हाँ,
साइंटिफिक
एक
सेशन एक्सीलेंट था बनारस का।
नहीं नहीं
साइंटिफिक
excellent.
सेशन, साइंटिफिक सेशन बनारस का।
हॉस्पिटैलिटी भी बहुत अच्छी थी भाई,
अरे
कितनी
बहुत
बढ़िया हॉस्पिटैलिटी थी।
मच पूछिए सर। एंड दर्शन से वन ऑफ द फाइनेस्ट इन माय लाइफ,
यस,
माने विश्वनाथ जी का दर्शन भी हम लोग का वन ऑफ द
अच्छा क्या लोग हैं, क्या लोग देख लो। मैंने ठीक नीचे।
आई थिंक अभिषेक जी स्टार्ट करवाइए, वी कैन स्टार्ट नाउ।
अरे अभिषेक सब रेडी है ना?
Yes, sir, we can start.
हाँ गो है
Okay.
अभिषेक, क्योंकि 2 स्पीकर हैं।
टॉपिक बड़े अच्छे अच्छे हैं।
हाँ।
Good evening, everybody. On behalf of Clinical Cardiodiabetic Society of India, I welcome you all in our virtual CME program. As you all know, every alternate month, we organize a CME under this banner. And another alternate month, our sister organization, Indian College of Cardiodiabetology, organizes CME program. So almost every month, we have one CME program. As you all know, this is going to be the last semi-program of current session because next month we have annual conference and annual general body meeting at Kota, and thereafter the next session will begin. So I hope the next session also will be as useful for all members as it was in the previous year. The topic we have decided to discuss today are of immense importance in clinical practice. The first topic is recent trend in management of obesity. As you all know, obesity is a very, very common problem. It is considered the mother of many non-communicable diseases. And all of you will agree that in the recent past, management of obesity has witnessed a sea change, especially after introduction of newer molecules like liraglutide, semaglutide, tirzepatide, etc. in our therapeutic armamentarium. To discuss this topic, we have with us Dr. Akash Singh from Baroda. And to chair this session, we have Dr. D.P. Khaitan, our past president and past team. And Khaitan Sahib is known all over the country for his contributions towards ECG. So I welcome Dr. Akash Singh and Dr. D.P. Khaitan. The second session, we will discuss a very unique topic, the upcoming subject, artificial intelligence in diabetes. Again, we all know artificial intelligence is coming in a very big way, and we are really confused and debating for last 2 years whether this is going to help us in our clinical practice or it is going to sabotage our future. Well, we have with us a very brilliant orator, a very well-known person, Dr. Arvind Jagdisha. I hope I pronounce your name correctly, Arvind.
Yes, sir. Yes, sir.
And he will discuss the pros and cons of artificial intelligence. The same person will speak the plus and minus point of it. And the chairperson is none other than Dr. A.K. Virmani. He is the current dean and past president of Ccdsi. And he has got keen interest. He is a big promoter of artificial intelligence in our profession, in our fraternity. And he is a wonderful organizer. We have seen his ability a couple of months ago at Lakshdeep. It was a wonderful show. So once again, I welcome Dr. Arvind and Dr. Virmani on this occasion. Both his speakers will be introduced formally by our Joint Secretary cum coordinator of the CME, Dr. Abhishek. So I did not say much about them. I hope Abhishek will present a proper biodata of both the speakers. The scientific session will be preceded by an introductory remarks by none other than our President, Dr. Madhukar Rai, and it will be followed by concluding remarks by our founder president and guardian of Ccdsi, whose vision has led to the foundation of this organization, that is Dr. Professor Rai. So without wasting much time, I request Abhishek to go ahead with the Saraswati Vandana Then we will invite Dr. Madhukar Rai for his introductory remarks and welcome address.
तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Thank you, Abhishek. After this Saraswati Bandana, I humbly request for blessings of our founder, president, and guardian, Dr. A.N. Rai. Sir, please declare this CME open and give your blessings.
At the outset, I would like to congratulate both Dr. Lohani and Dr. Birmani for having regular CME throughout the year. And today is the last session. And everybody will aware that we have covered all the relevant topics. Today, learned speakers are going to speak. Already Dr. Lohani has spoken of the topics. I have nothing much to add. But I want to say a few things that both the speakers are very brilliant and good orator. And we are going to learn few new things. And equally important is the chairpersons. They are the vital of CCDSI. And we are going to hear the comment. And with this, I open the CME program and I request Dr. Lohani to start the session.
Thank you, sir. Thank you very much for your kind words and appreciation. And it's time now to request Dr. Professor Madhukar Rai, our president, under whose shadow we worked throughout the year, and I hope we did quite well. So, Dr. Madhukar Rai, sir, for your introductory remarks, you are welcome.
Thank you, Professor Lohani, for organizing this wonderful CME and for CCDSI for having a continuous stream of CMEs on contemporary issues. And this, the last one is not the least. It is one of the going to be the most important one, the most emerging issues, obesity. When we were students as looking at obesity, we always used to talk about monogenic obesity or a syndromic obesity, which was the theme of treatment, like leptin deficiencies and Prader-Willi syndromes and other things. But suddenly, over the last 20 years, we have developed a polygenic sort of or socially determined obesity. And this is a very, just like a diabetes, this is a very, very heterogeneous disorder. Even if you look at, and unfortunately, we don't have any tool to decide what is the level of heterogeneity in obesity. Because some person will respond wonderfully to semaglutide, another will not. Someone will lose about 20% of body weight, another will lose only 5%. So we don't know exactly what is happening inside the body, but the old concept of what is called as a energy homeostasis to socially driven eating disorder to hedonic pleasures have taken up the center stage, and now obesity being considered as one of the most complex, just like type 2 diabetes. It's the most complex situation and very difficult to handle. So for this, and you know that unless we control obesity, all the drugs, whether we are treating for hypertension or for lipids or for diabetes, everywhere the center of focus is weight control. So defining obesity per se or obesity versus adiposity, because different population has got with the same BMI, different adiposity. And for each population, we have to define what is the obesity. And just like diabetes management, we have to go for a SMART goal. That is, we have to define what is specific for management of obesity, which is measurable, how much percentage of weight loss do you expect in this patient? What should be the goal? A metabolic dysfunction, or a weight loss, or a mechanical problem, or sleep apnea. So these issues have made management of obesity very complex, patient selection very complex. And I hope the speaker is going to do justice to this. Another thing, AI, or Dr. Virmani rightly said, it is assisted intelligence. But soon we are going to get AGI or ASI, which is a knowledge-based, and then it will start taking its own decision. As on today, AI is essentially based on algorithms, and in medicine, probably one of the best utilization of AI has been the comparison of different X-rays and pathologies for photographs and other things, and which you can match from an algorithm. But as we evolve, it will start taking its own decision. And it has helped us in making a differential diagnosis. And of course, we have to utilize our own mind till the AI gets the knowledge and the super knowledge AI. So on that day, probably the doctors will start feeling themselves redundant if the AI starts taking its own decision. And Dr. Arvinda will be taking you through all the nuances of artificial intelligence. And with this few introductory remarks, I welcome you all to this CME, and with a lot of hope that CCDSI will continue to give this type of CMEs so as to introduce to the latest nuances of the contemporary issues. And long live CCDSI. Thank you so much, Dr. Lohani. And may we proceed with the CME.
Okay, thank you, sir. Thank you very much for your kind words. And now I request Dr. Abhishek to introduce both his speakers, and thereafter I will request Dr. D.P. Khaitan to take over the charge of this first session. So Dr. Abhishek, please.
Thank you, sir. Good evening to all the respected teachers and honorable members of the association. As told by all of you that we are having some important topic to be discussed today. For the first topic, the speaker is Dr. Akash Singh. Sir is known to all of us. Sir is MD Medicine, MSc in Diabetes, and having fellowship of all the important organizations in the field of cardiodiabetology. We all know his brainchild IDCM, Indian Diabetes and Cardiometabolic Disease Association, of which he is the president. And under his guidance, this association is gaining more and more wide coverage across the globe. Sir has been our founder, chairman, and key figure for the state of Gujarat on the point of CCDSI. So welcome you, sir. you are also associated with almost all associations, including Association of Physicians of India, RSSDI and all. The second topic will be covered by Dr. Arvinda Jagdisha, sir. He is MD in Medicine, MRCP and Triple FRCP. He has been the chairman of the Dr. Arvinda Diabetes Center, Bengaluru. And we all know that his annual conference also is a worldwide famous. And we have already learned under him in various platforms, both online and offline. He is one of the prominent diabetologists from the state of Karnataka and has been leaders in many associations, including having got the post of chairman of the RSSDI Karnataka chapter. Sir, I also welcome you, and I hope that both of you will give a vibrant session for today's CME. Thank you, sir.
Thank you, Abhishek. Thank you very much. Now I request Dr. T.P. Khaitan, the chairperson for the first session, to take over the charge of this first session of today's CME. And I humbly remind the chairpersons and the speaker that the session will have 30 minutes time. Out of that, 20 minutes for the speaker and 10 minutes for chairman remarks and floor participation. So I humbly request both of you to stick to the time so that we can have enough time for the other activities. Dr. Khaitan, please take over.
Thank you, Dr. Lohani. My regards to Dr. Professor N. Rai and all the stalwarts of present there. It is my privilege and pleasure to not only introduce, but also request Dr. Akash Kumar Singh to speak on the topic. But before that, I want to say something about him. मैं गुजरात की भूमि पर खड़ा हूँ और एकटक देख रहा हूँ आकाश और जमीन के मिलन को. He is so famous, even the sword of Gujarat smells his repute whenever we pass through Baroda or like places. He's so famous. He's so friendly, we can't describe it. Once upon a time, he was holding my mic and I was managing the show of the EC show in Gujarat. He was so nice and so gentleman. Anyhow, however, without spending any time, I just want to introduce the subject by 2 or 3 sentences. The exercise or lifestyle changes or modification in controlling or managing the oversight is all known to us. But nowadays, there is a change trend in terms of the pharmaceutical treatment, apart from the bariatric surgery. Our pharmaceutical treatment consists of 2 parts. Number 1 is the monoglycogen sort of the polypeptide action and dual action by the GLP-1 and GIP both. Commonly known as Monjaro is very useful. And I am having the experience of Monjaro in the treatment of my wife.
30 modern luxury.
In the treatment of my wife. She is having a BMI of 38 and getting started the Monjaro by 2.6 milligrams subcutaneously weekly and getting good response. Just after 2 injections, he lost the weight about 5 kg. So good start. And this other part of the drugs also, but we have to take the care of the side effects of the drug before starting the therapy, like the GIT effects, nausea, vomiting, constipation, etc. Even sometimes pancreatitis and gallstones, especially with care to the thyroid. And all things will be dealt by Dr. Akash Kumar Singh, and I request directly him to start the talk without wasting any time. Dr. Akash Kumar Singh, please.
Thank you very much, sir. I'll just upload my slides. The slides are visible?
Yes.
So actually, it is a very long topic, and because I was not knowing about the topic, I've got plenty of slides. So I will go very fast through the slides. I'll be talking about recent trends in the management of obesity, and before talking about recent trends, I will go about the basic facts about obesity. And in these headings, I will be discussing the entire topic. So basically, you know that 1 in 8 people are obese, and the numbers are astronomical. In India, in the ICR in-depth study, you can see that almost 254 millions with generalized obesity and 351 with abdominal obesity. So we have lot of people who have normal weight obesity also. They are not obese, but they have more of visceral fat. Now, this is the international classification of obesity where less than 25 is 18.5 to 24.9 is the normal, and 25 to 29.9 is increase, that is overweight, and 30 and beyond stage 1, stage 2, stage 3 obesity. But does it hold true for Indians? A lot of research by Dr. Anup Mishra and his group ultimately found out that Indians have more visceral fat at lower BMI, and therefore we have reclassified obesity as 18.5 to 22.9 as average, more than 20 overweight, and we have basically more than 25 will be classified as obese basically. And similar report has been published by Lancet recently, where the obesity in India is overweight and obesity is beyond BMI of 23. Now, if you see the pathophysiology of obesity is a multifaceted problem. No single drug can cause a reduction in obesity. You have to address multiple pathophysiologies in obese patients. And it is not simple calories in and calories out. It is much more than that, basically. And these are the salient hormones which are produced at the level of adipose tissue, which have impact on obesity and also the subclinical inflammation. So if we go to the first hormone, that is leptin, basically, leptin is a good hormone, and the resistance to leptin develops in obese patients. Appetite remains high, which it is supposed to suppress, energy expenditure does not increase, and it promotes weight gain. So there is a state of leptin resistance in obese patients. Adiponectin is another good hormone produced by the adipocytes, which is also reduced in obesity, contributes to insulin resistance. There is an increased atherogenic and inflammatory risk with decreasing adiponectin. Omentin is produced by the omental tissue, and it decreased levels are seen in central obesity, which leads to impaired insulin action, increased endothelial dysfunction, and cardiovascular risk. Keberin and RB4 are other two chemokines at the adipose level, tissue level, which are increased in obesity, and they promote chronic low-grade inflammation, insulin resistance, and metabolic syndrome. We have other chemokines like the serpin A2, fatty acid binding proteins, ASP, PAI. All of these basically cause are strong risk factors are of metabolic syndrome, and elevate your ASCVD risk. And they are now being developed as therapeutic target or biomarkers for the risk in obesity. Apart from that, we have activation of the RAS activating system, which also contributes to increased incidence of inflammation and hypertension and metabolic syndrome in patients who are overweight or obese. So if you see the obesity and the risk of developing type 2 diabetes, lifetime risk of developing diabetes in obese patients can go up to 70 to 80% in males and females as the BMI increases. So 80% of the obese patients are 80 times more likely to develop type 2 diabetes. Abdominal fat, because of ballooning of the adipose tissues, the vascular supply to the peripheral adipose tissue decreases. They become ischemic. There is release of pro-inflammatory cytokines, and that leads to a pro-inflammatory milieu, subendocrine dysfunction, insulin resistance. The body metabolism also changes, basically the free fatty acids, because there is a resistance to lipoprotein lipase basically, and these triglycerides spill over in the circulation, go to the liver, and they are taken up by the liver, acted upon by the liver lipases, and a state of de novo lipogenesis occurs, which leads to excess production of VLDL and atherogenic lipoproteins, which causes a state of generalized inflammation and accelerated atherosclerosis and plaque formation. There are various endocrine disorders contributing to obesity, and you can see all of this listed here: growth hormone deficiency, hypothyroidism, hypothyroidism, insulinoma, a host of disorders. There is a hypothalamic obesity also. A lot of genetic factors are also incubated. So, a patient of obesity should not be blamed for obesity, saying that he's eating more or he's not exercising or he's not taking, because a lot of factors which are present and which lead to genesis of obesity are not in control of the patients. Now, what happens? The obesity has mechanical effects and metabolic effects. Mechanical effects are in the form of joint disease. The metabolic effects are in the form of PCOS, pregnancy complications, infertility, subfertility, hypogonadism, MASLD, MASH, sleep apnea, asthma, depression, anxiety, stroke, diabetes, pre-diabetes, dyslipidemia, hypertension, CAD, pulmonary embolism, heart failure with preserved ejection fraction, very important. Thrombosis, chronic back pain, GERD, all of these basically are the mechanical effects, and others are the metabolic effects. So basically, it has metabolic effects and effects on the because of the excessive weight, basically. Now, cardiovascular kidney metabolic syndrome is very, very common in obesity. All the complications of type 2 diabetes, whether it is nephropathy, neuropathy, retinopathy, is a it involves multiple pathologies. Apart from blood sugar, it is obesity, dyslipidemia, hypertension, hyperuricemia, everything goes in ectopic fat deposition in the pancreas, kidneys, etc., which goes into create CKM complications. In stage, there are no risk factors, but in stage 1, basically, overweight, obesity, abdominal obesity, and impaired glucose tolerance, but there are no other risk factors. In stage 2, we have metabolic risk factors like hypertension, metabolic syndrome, moderate to high risk CKD, type 2 diabetes, hypertriglyceridemia. This progresses to subclinical CVD in CKM syndromes, which progresses to full-fledged CKM syndrome, where there is established coronary artery disease, heart failure, PAD, stroke, atrial fibrillation. So, therefore, addressing the epidemic of obesity is very important if you are to prevent all these metabolic complications. Now, there are very strong recommendations for treatment of obesity, and care is emerging. We have certain proven molecules for decreasing ASCVD risk, like GLP-1 receptor agonist, SGLT2, but the guidelines are not being uniformly followed, although the numbers of patients being offered these therapies are increasing. However, there are some logistic reasons like cost and all, which impair the use of these drugs. Now, limitations of BMI, we no longer look at BMI alone in defining obesity because of several factors: body roundness index, height to weight ratio, waist circumference also has to be taken into account, as per the latest dictum from Dr. Anup Mishra, who is very correct in his thinking. We can have overweight population with excess body weight, but with no signs of symptoms, and there can be underdiagnosis of obesity. You can have excess body weight, higher BMI without excess body fat, like you see in wrestlers, like you see in the gymming population, and their obesity can BMI may dictate that patient is obese, but patient is actually not obese because he does not have excess fat, and there may be overdiagnosis of obesity here. There may be in obese population excess body fat, but no signs and symptoms, and this is obesity with preserved health or subclinical obesity, and you can have both signs, symptoms, as well as higher BMI, which and higher fat percentage, which is a obesity with ongoing illness, which is a clinical obesity. So a more accurate and clinical relevant approach is preclinical obesity, where you have excess body weight but without metabolic complications, and they are at higher risk. However, they generally have the physical complications of obesity because of overweight, but no metabolic complications. So 80% of obese patients are having some metabolic derangements, but 20% of them are not having metabolic derangements. Clinical obesity is where you have signs, symptoms, or presence of risk factors or the target organ damage already being there. So basically, for a patient who has excess obesity, you take the BMI, waist circumference, and if there are no alteration of cell tissues or alteration of organ structure, which you see, so there basically, if the symptoms are minor or absent, basically, you can diagnose it as preclinical obesity. However, if there are alteration of organ functions and organ damage, signs, symptoms are there, limitation of daily activities, complications, that basically would classify as clinical obesity. So we have several sort of examples here. This is a BMI 23.7, and there is no excess body weight. Signs, symptoms are not present, and therefore this patient just has overweight status, but does not have clinical obesity. There is a second person who has 28.8 BMI without excess body fat, with normal muscle mass and signs, symptoms absent. He is also overweight, but there is no obesity. Likewise, the second person with 28.8 BMI has excess body fat, muscle mass being normal, and no sign symptoms. He has preclinical obesity. If this is a second person with 32.4 BMI, but without excess body fat, high muscle mass, without sign symptoms. This has mechanical. This may have mechanical complications of overweight status, but no obesity. And the other two with 39.2 basically are having preclinical and clinical obesity, because 1% does not have signs and symptoms. So you have to basically weigh in the BMI status with the fat analysis, analysis of muscle mass, signs and symptoms, and subsequently classify, and the presence of other risk factors or comorbidities to classify your patients into different stages. And for this, we have Edmonton obesity staging system, which basically takes into account all of these criteria basically, and stages the patient from stage 0 to stage 4. And as per the staging of the patient is offered a lifestyle modification only, or lifestyle modification with monitoring, or lifestyle modification with medical intervention, or aggressive medical and surgical treatment. And patient basically is treated as per this scale basically. So this scale is also complementary to the earlier measurements which and the classification of the patient which we did on the criterias which are present. Now coming to the role of brain in controlling appetite, we have homeostatic eating and we have hedonic eating. Now homeostatic eating is eating to gain the calories which are required to run the metabolic processes on day-to-day basis, and will see the effect of hormones here. The hedonic eating has become very, very common in present day circumstances, because we are eating more than what is required, and this eating is for pleasure basically, not to replenish the calories which are required. And dopamine basically is one hormone which controls wanting, motivation, drive to eat, and opioid and cannabis receptors control liking and pleasure associated with it. And hedonic eating is getting more common, which is contributing to the epidemic of obesity. Lifestyle, executive function, behavior interventions to impart sustainable control of eating is very, very much required. And because we are landing up with the epidemic of obesity. Coming to the hormones which control the homeostatic eating, ghrelin stimulates appetite, basically is the only appetite stimulating hormone produced in the stomach. It has blunted effect. It has its effect basically in causing postprandial suppression is blunted. It is chronically elevated in some obese individuals, contributes to overeating and weight gain. CCK, GLP-1, and oxytocin basically are produced again in the gut. Basically, they are appetite suppressants, but their effects are sort of mitigated in obese individuals. They fail to control the appetite, and there is a state of overeating these patients. Now, if you see the magnitude of weight loss and benefits, you can appreciate in this slide that as you have incremental weight loss, the metabolic benefits improve, and the maximum benefits are seen at weight loss beyond 10%, where you can have type 2 diabetes remission, where you can have improvement in MASLD, which is the hepatic, polycystic ovaries, hypertension, dyslipidemia. Weight loss is the single most useful non-pharmacological lifestyle intervention, which can lead to amelioration of a host of chronic diseases. Hyperuricemia is also addressed with weight loss. So you have to aim for a weight loss beyond 10% in all patients who are having higher visceral fat, even if they are not obese. Now, coming to the strategies for obesity management, you have psychological intervention, pharmacological therapy, and bariatric surgery. Now, for anti-obesity drugs, the earlier drugs we used were orlistat, naltrexone, biparon, which caused up to 3 to 5% of weight reduction. But because of various reasons, they could not find favor, and this much weight reduction was not sufficient to meet our metabolic demands. And then came liraglutide, which in the dose of 3 milligram per day could cause 5 to 8% weight loss in various trials, and was the first approved drug for weight loss amongst the GLP-1 receptor agonist. Semaglutide did better basically, and Wegovy with a dose of 2.4 milligram once weekly causes substantial weight loss. And these are central effects which are shown of these drugs. Although orlistat has only peripheral action, but others also have central action, which contributes to weight loss. Now, coming to the most important drugs for weight loss, that is the overview of incretin-based therapies. They play a key and early role in maintaining blood glucose homeostasis. Incretin effects diminishes in type 2 diabetes. They target multiple effects of diabetes, which are peripheral because they retard the gastric emptying, also have central effects also. And these drugs basically have opened the door for the obesity management, pharmacological obesity management, and the field has got exciting day by day. They basically act at the level of adipose tissues, kidneys, heart, brain, muscles, bone, liver, and pancreas, and gut, and their various effects on all of these organs basically contribute to weight loss and improving the metabolic profile of these patients. And it is no surprise that in addressing so many pathologies which cause inflammation, they are the key drugs for reducing the ASCVD risk in your patients of diabetes and otherwise who have excess ASCVD risk. So they have potent glucose lowering, select agents approved for cardioprotective benefits, potential kidney benefits, low risk of hypoglycemia, weight loss is common, oral semaglutide also is available. So the oral formulation is also now available. Limitations are adverse GI effects. A majority of them are injectable, and thyroid C-cell tumors and acute pancreatitis, they should not be used in the setting of acute pancreatitis. Now, coming to the dosing administration, you can see that liraglutide, which is shaded in dark blue, exenatide, dulaglutide, and exenatide are all basically the main drugs which cause weight loss basically, are liraglutide and semaglutide, although dulaglutide also causes weight loss basically. But the indication, the approval for weight loss is with liraglutide and semaglutide 2.4. Now, GLP-1 receptors approved for severe risk reduction are liraglutide with the LEADER trial, dulaglutide with the REWIND trial, and semaglutide with the SUSTAIN 6 and the recent host of trials. All of them are now approved for severe risk reduction. However, the weight loss indication rests with liraglutide and semaglutide and not with dulaglutide. So GLP-1 adverse effects, we will not discuss. Everybody of you know your dose dependence, typically mild and gradually resolve, and we gradually step up on therapy, start with the lower doses and step up on those required doses to sort of mitigate these effects. Now, coming to the weight loss with various GLP-1 receptor agonists, you can see that earlier liraglutide caused a maximum of 8% weight loss in across various trials. However, that was liraglutide 3 milligram dose. However, the semaglutide has done better basically, and triglyceride is even better. But because we are comparing the GLP-1, you can see that the green line is semaglutide 2.4 dose, and it causes a good amount of weight loss basically. Now, this is the trials which are scale trials with liraglutide 3 milligram, and you can see up to 8% weight loss with these drugs basically. And you also have to continue these drugs on a maintenance dosage, because if you stop these drugs, there is tendency to regain weight basically, and therefore these drugs have to be continued. The step one trial, where this effect of semaglutide 2.4 milligram weekly on body weight in patients without diabetes, you can see that there is a good reduction and almost 15 to 16% weight loss with semaglutide 2.5 milligram in this trial. There is availability of oral semaglutide, which we are using up to 14 milligram dosing, but this trial done with 50 milligram semaglutide orally basically could lead to a body weight reduction of 15.1% in adults with overweight or obesity without much excess side effects. And this trial was done, and maybe we'll have oral semaglutide 50 milligram in recent times with approval of treatment for obesity. Now, this is a second oral GLP-1 orforglipron basically, which is a drug which is a non-peptide GLP-1 receptor agonist. And here the advantage is that fasting is not required for taking this drug basically. And the results also are fantastic. You can see almost 15% weight loss with this oral drug for obesity. And so this drug is under development and may hit the market in coming times. Regarding the cardiovascular risk reduction with incretin therapy, you can see that meta-analysis of GLP-1 receptor CVOTs, leader, sustain 6, rewind, amplitude O, all of these trials basically showed a very, very good reduction with various agents on MACE and CV outcomes. On the hospitalization of heart failure, also the benefits were seen, and with majority of the drugs which are in market today. There was 20% in select trial, that is semaglutide, there was 20% cardiovascular risk reduction in 3-point MACE, 15% numerical risk reduction of CV death, 18% risk reduction of heart failure endpoints, 19% reduction in all-cause death, 9.4 sustained weight loss for 4 years, 22% reduction in kidney endpoints, and 73% risk reduction in developing diabetes. So a host of benefits, 2.4 semaglutide, 37% benefit in the following endpoints, which are listed in the slide on the right side, basically. So a very good drug to address the atherosclerotic cardiovascular risk, and on the renal front too, basically. So this was the step heart failure with preserved ejection fraction. And you know that ectopic fat basically is one of the key drivers of developing heart failure with preserved ejection fraction. And there is a crosstalk between the ectopic fat and the endothelium. Ectopic fat leads to excess atherosclerosis generation at the coronary endothelial level, and therefore removing this ectopic fat leads to improvement or less onset of heart failure with ejection fraction. And this is amply seen. The quality of life score basically improved very well with the after the semaglutide is given. It is a better quality of life. The body weight decreased to tune of 13.3%, which is beneficial for patients of heart failure with preservation fraction. And you can see that 6-minute walk test, patient could walk better and could walk more distance without breathlessness with use of these drugs. So these drugs are beneficial as far as the heart failure with preservation fraction is concerned. Coming to the SOUL trial with oral semaglutide, you have decrease in MACE to the tune of 14%, and all three components of primary endpoints contributed to superior MACE reductions demonstrated by oral semaglutide. And therefore, basically, this drug is now the oral drug is also approved for prevention of ASCVD. So to summarize, the GLP-1 receptor agonists in type 2 diabetes, they have good potent glucose lowering efficacy. Hypoglycemia risk is minimal. There is weight loss, and very, very good weight loss with certain agents. It has strong CV indications in the form of prevention of ASCVD and heart failure risk and emulation of the heart failure. They have good effects on renal effects, and the trials were halted basically because semaglutide was associated with the reduced risk of kidney outcomes in DKD, and they are the second drugs basically after SGLT2 as far as the diabetic drugs are concerned in addressing the CKD issue. Adverse effects are we already discussed. So we have potent reduction of hyperglycemia, a good ASCVD production, a good loss of weight, and all of this translates into their being a versatile drug acting on the metabolism and causing favorable conditions on the kidneys, on the heart, and overall metabolic profile of the patients. And they act via several mechanisms on the skeletal muscles, systemic, via adipose tissues, pancreas, central system, and cause their good metabolic effects. Now, the difference between GIP receptor agonism, now GIP is a very transient molecule in the circulation, and elevating GIP was therefore initially not in the option. So we went ahead with GLP receptor agonist. Now, why the GIP and GLP combination came? Because GLP-1 addressed only the single pathophysiology in obesity. So the effect of GLP used to plateau off after some time, and we are not achieving incremental benefit after achieving the plateau. So therefore, it was thought that we should go for a further innovation to cause more weight loss. And for that purpose, GLP-1 and GIP were combined basically. GIP has chances of less nausea compared to GLP receptor agonist, and they have complementary silent effects. They address two of the pathologic features of diabetes. And tirzepatide was the first molecule which was developed, and we have dosing from 2.5 to 15 milligram, and we have several trials with this. The problem with tirzepatide is that we do not have the data of the CVOT trials, the robust data of CVOT trials like we have with the semaglutide, basically, because this is a newer drug and the trials, multiple trials have to be done to prove their CV efficacy. However, the effects on the weight loss are dramatic, basically, and you can see that patients achieve in these trials up to 13 to 14% weight loss. These are the surpass trials, basically. However, the new trial, basically, you can see that almost 13% weight, and this trial was done in comparison to 1 milligram semaglutide, and the dose of 15 milligram because 1 milligram semaglutide caused around 6.7% of weight loss, and the 2.15 milligram of tirzepatide caused around 12.4 kg, that is 13% weight reduction. This was not compared with 2.4 semaglutide, which is the standard of care as far as obesity management is concerned regarding semaglutide, basically. Now, this was a surmount one, and the data was even more robust, and there was almost 22% weight reduction with 15 milligram tirzepatide. So this molecule basically has higher weight reduction compared to semaglutide, and is now the preferred molecule for obesity. But let me tell you that the ASCVD risk is better and more evidence-based molecule is semaglutide to address the ASCVD risk, the heart failure risk, the renal risk, and the weight loss. So if you see all of these four parameters, the preferred molecule as of now is semaglutide. Till we have more data on tirzepatide with regard to renal endpoints, CV endpoints. So basically, it is preferred more only for the incremental weight loss that it causes. The other molecules which came in, which are being brought in, basically, is retatrutide. This is a triple agonist, that is GLP-1, GIP-1 receptor agonist, and a glucagon receptor agonist, basically. And it has shown even more weight loss compared to semaglutide and tirzepatide to the tune of around 23 to 24%. So we are approaching almost the bariatric surgery levels with the use of newer and newer molecules. In this molecule may be introduced shortly after the trials are completed. Now, patient education helps address the potential adverse effects of getting therapies. Now, coming to the place in therapy, use of glucose-lowering medications in the management of type 2 diabetes. Efficacy for weight loss is very high for retatrutide, for semaglutide and Mounjaro. Very high for semaglutide, tirzepatide, high for dulaglutide, liraglutide, intermediate for GLP-1. So the place for liraglutide is because it has become generic, so we can use it to induce weight loss in our patients if Cost is a major constraint. Otherwise, semaglutide and tirzepatide are the better molecules. Tirzepatide is in waiting basically, and once introduced, it will be even more incremental in causing weight loss. Cagrisema is a molecule where the amylin agonist is combined with semaglutide 2.4, and this also is causing 18% weight loss in various trials. And all of these agents are coming in because once you start a particular drug, it addresses particular pathophysiology of diabetes, but gradually the effect plateaus off, and the other pathophysiologies also have to be addressed, and replacing the drug with another drug or supplementary the drug with another drug basically can cause incremental weight loss. So obesity-related comorbidities are addressed with these drugs. There is improved glycemic control, protecting heart and kidneys, substantial and sustained weight loss, steatotic liver disease addressed, diabetic eye disease addressed, dementia and OSA is addressed with these drugs. So this is a comparison. There is another drug which is glutide, which was a Sanofi drug, which the development Sanofi has discontinued because there is the GLP market is crowded. Basically, there is very less scope for profitability in the GLP market. So it has handed over this drug again to the original South Korean company which had developed this drug. But this is also very good drug basically, and you can see that the weight loss is now with newer drugs approaching 20 to 30%. Now, HbA1c change in people with diabetes, obesity, medicals in development. You can see the HbA1c change is also robust. We are achieving more than 2% of the HbA1c reduction in a host of new drugs, basically. So, another drug, two drugs which are in phase 2 and phase 3 trial are pemvidutide and semaglutide. And what they do is they have incremental effect on reducing liver fat, and semaglutide also reduces the liver fibrosis also, and these two drugs, once launched, will be the preferred drug in addressing obesity with MSLD or cirrhosis liver. So this is the flow chart. Adults with obesity, does the patient have NASH? If the patient has NASH, in future we'll have pemvidutide and semaglutide as a preferred drug. Does the patient has pre-existing CVD? Semaglutide without doubt because of the maximum data. Otherwise, you can use dulaglutide or liraglutide. Does the patient have type 2 diabetes? If patient does have, does the patient has nephropathy? If type 2 diabetes nephropathy, then the sole drug is semaglutide. Basically, other drugs are in waiting. If the patient does not have nephropathy, only diabetes, then you have to see the target body weight loss, which is to be achieved. And depending on that, you can use semaglutide and tirzepatide, and the other drugs can be used if cost is a problem like liraglutide. If the patient doesn't have diabetes, then you have to decide how much weight loss, and accordingly you decide the drug which is to be used. If the patient has OSA, you will want more weight loss, and there tirzepatide should be used basically. Coming to the bariatric surgery, the indication is BMI more than 35 with comorbidity or BMI more than 40 without comorbidity. However, in Indian patients, we consider BMI 35 without comorbidity as an indication of surgery, BMI more than 30 with comorbidities as an indication of surgery, and even at BMI more than 27.5 with comorbidities in shared decision making with the patient, you can offer bariatric surgery to your patients, because if weight loss is not addressed, these patients will have poor quality of life and early morbidity and mortality. The bariatric surgery benefits is early weight loss, sustained weight loss. The minimally invasive procedures have lesser weight loss like adjustable gastric bending or sleeve gastrectomy, although the morbidity and mortality in these procedures less. Roux-en-Y gastric bypass has more morbidity and mortality, but better weight loss, more sustained weight loss, and more sustained metabolic control, including diabetic remission. Biliary pancreatic diversion is the major metabolic surgery which has higher effects. However, this surgery leads to a lot of vitamin deficiencies and other parameter deficiencies, and is the last option in your patients basically. So these are the recommendations which already we have discussed basically. Now these were the type 2 diabetes remission after bariatric surgery, and you can see that several of these studies have been 10-year follow-up and 30 to 40% remission even at 10 years. This study which stands out is the Rubio Almanza study, where at 5 years you have almost 92% diabetes remission. And the cause for this basically is that they were very selective for the patient. They took patients who had early diabetes, metabolic healthy obese patients, and they offered Ruin YGB, which is a major metabolic surgery. And they had a very structured program for follow-up motivation. And that is the reason others took long-standing diabetes. The follow-up was not meticulous. Some derived data from the EHR where patients were not meticulously followed, and therefore they do not have this good results as is seen with this. Now, this bariatric surgery is associated with number of perioperative and short-term complications, which we'll not discuss because it is not pertaining to our talk basically. Now, to summarize, obesity is a clinical disease with a complex etiology and significant impact on patient's health. Diagnosis should be appropriate considering multiple parameters to diagnose obesity. Do not rely solely on BMI. Weight management should be supervised by a qualified multidisciplinary team, providing the patient with full access to necessary information and individually tailoring therapy regimens. No single method can provide optimal results. Newer agents, GLP receptor agonists, dual GLP, GIP agonists are very promising and reliable treatment options for obesity. Thank you very much.
Thank you, Dr. Akash Singh. Excellent talk by you, covering all the aspects. I must congratulate you. And now the hours of asking questions is open to the house. Please.
Yeah, Dr. Khaitan sir, can I have some comments?
Yes, sir.
Okay. At the outset, Dr. Akash, it was an excellent talk. You have covered the subject extensively and your slides were superb. I have some comments to make.
Yes,
First of all, obesity has got phenotypes. We are learning something new now. Not all obese people have an adverse outcome. What we earlier thought was metabolically obese, healthy people, now we are learning that these people do not have any problems later in life. So to classify obesity as a clinical disease, somehow I do not agree. It is basically a metabolic problem, metabolic disease, and we have to sift what is harmful and what is not harmful. Now, when we talk about excessive deposition of fat in the visceral tissue, the question is, it is not only the excessive deposition of fat in visceral tissue. Wonderful studies done by Dr. Anup Mishra have shown that it is also in the subcutaneous tissue. We were always under the impression that subcutaneous tissue is harmless, but he has shown that in the deeper subcutaneous tissue, deposition of fat is harmful. Now, what that brings us to a conclusion, it is not the ectopic distribution of fat or a collection of fat, it is basically a dysfunctional fat tissue. And by just reducing weight, we are not taking care of the dysfunctional fat tissue. We are just reducing the fat. That is one very important point, that we are learning something new that has come up recently. Second point, just reducing weight is not the answer. Even without reducing weight, we can reduce the risk. And there has been a lot of adverse criticism regarding the advertisements made for GLP-1 receptor agonists, and there is almost like a horse race, which is going to cause more weight loss, 10%, 15%, 20%, and all that. And the American College of Cardiology just 3 days back have given a wonderful statement that we do not agree with this point that GLP-1 RAs should be recommended as first line for the treatment of obesity, because that gives a wrong message that is the answer, and you are going to tell the patient, okay, I've got a drug for you, and you're not going to think about the basic thing, that is intensive lifestyle modification. So intensive lifestyle modification still remains as the main pillar for the management of people with dysfunctional fat mass, and this is just an adjunct. Number 3, when we talk about comparison between the use of anti-obesity drugs and bariatric surgery, the choice often falls on bariatric surgery because despite the risk of surgery, we know that's a one-time procedure. And this is a lifelong treatment, and you cannot say that today you give it and tomorrow you stop it. You have to continue lifelong. And patients cannot afford it. Affordability is a big problem. Whereas for bariatric surgery, it's a one-time problem. And then we have now not 10 years, we've got 20 years data that this is not only weight reduction, but metabolic effects are being noticed. So possibly there is something more with bariatric surgery that is happening. So all these new things we are learning, and as far as the GLP-1 RAs are concerned, we should not be overzealous to use them, because a lot of skeletons have started tumbling out of the cupboard, and we don't know how many more are there. You must have heard recently about the Ozempic face, Ozempic mouth, the skin and the glamour goes away. So there are a lot of side effects. It's not only the loss of appetite and all that, loss of taste is there. So these things have to be used very judiciously. And that is, I think, the comment that I wanted to make.
So the comments are very much relevant because lifestyle modification remains the cornerstone, because unless you emphasize on lifestyle modification, unless the patient follows lifestyle modifications, none of these drugs are going to be useful in the long run. They may have initial temporary benefits, but again, all of these metabolic derangements are going to come back. There is data in the US basically about the 2-year use of GLP-1, and they have seen that in 2 years, almost 70 to 80% of the population gets off the GLP receptor agonist. And second thing with the issue is that you also have muscle loss along with the weight loss.
Absolutely.
And the weight gain which occurs after discontinuing is in the form of fat. So you land up with excess fat, lower muscle mass, and all of this is detrimental. The problem is that more than 90% of our population, despite repeated counseling and all, and a lot of us, we do not have time to counsel again. We counsel once or twice. They do not follow the lifestyle modification. Everybody wants an easy way out, and they quote different reasons for not following
No,
lifestyle modification.
I agree with you, Dr. Akash, that everybody wants a decent way out. But you said that we counsel the patients. My question is, are we doing enough counseling? Are we properly communicating with patients? We tell the patient you go for exercises and diet and all that. They don't listen to us. But when Baba Ramdev says the whole country is doing yoga, including the Prime Minister. So there is something wrong in our communication. There is something wrong in the way we are counseling. Let us admit our mistakes. It is very important to realize this.
So we doctors also are equally confused because some of the doctors are saying something else, some of them are saying something else, and therefore the patient is even more, because for such a costly therapy and all, they will consult 2-3 doctors and everybody is speaking on different lines. So all that is even more confusing to the patient.
So everybody wants an easy way out.
Can I?
Please, sir. Please, sir.
One thing is that
right.
Dr. Birmani, you very rightly pointed out that we know the effect of the drug, but we still are, a lot of skeletals are tumbling out of the side effects. And these side effects could be a problem. And then we have to very closely watching as the drug therapy is evolving as to what are the side effects. But one thing is somebody has very aptly said that GLP-1 is a agonist or a GLP-GIP co-agonist are a crutch for the patient of obesity, because once they are not losing weight, and with lifestyle modification you continue to do that, and then once you use these molecules, they lose weight and then get motivated, and once they are motivated, then you can maintain the lifestyle modification. But the studies are proving contrary to that. The moment you stop the drug, the weight gain rebounds back. So the Canadian Obesity Association, am I audible or not?
Yes,
absolutely.
Looking at the Baba Ramdev, 5 A's of obesity management. First of all, don't stigmatize the patient as obese. So you have to ask the permission to call them obese. Now we don't call it a person as obese, we call it a person diabetes with or a person with overweight. We don't call it as a person with a disease with more weight. This is a more respectable word rather than saying the mote ho and stigmatize it. Then you have to assess and very rightly assess. Even if your BMI is 27 and you are loaded with MASH and other metabolic problems or obstructive sleep apnea, that becomes a case for using a GLP agonist. So ask, assess, and then assist the patient in making a right choice. Continue to do so, and in between, help the patient with repeated counseling. Unless we have a whole cycle of this, 5 A's, we will not be able to achieve a meaningful weight loss, transient weight gain, loss, and then again you rebound back to the same. Because, this treatment continuation is very, very difficult, especially in India. So we have to think of something else also as a lifestyle. And Baba Ramdev, the way of communication, because he connects with the people. We doctors are connecting with the disease. We doctors are connecting with the disease, not with the people.
Correct.
We have to look at the patient's psyche, look at the social circumstances. And if you look at the ADA guideline, it says that assessment of the patient, priorities, social determinants of health. So when you're fixing up the goal, and then you decide upon a smart goal, which is realistic, actually you can maintain it for a long time. Otherwise, the whole thing is going to be a futile exercise. So we have to take this obesity management in a very, very long-term process of continuous counseling and patient education. And I tell you, if you are looking at the yogic practices, and one very important thing which I have learned in my clinical practices, when I ask the patient, even a rural population, that how mindful are you in your eating? When we talk of hedonic behavior, खाने का स्वाद और खाने की महक देख के खाने का वो हो जाता है, तो how mindful you are in eating. When you are eating, do you think that your body is a machine and which you are putting in something which is going to be harmful to you? So the moment with every bite you take, and if you are mindful, you may probably over long run get into a habit of eating less, eating proper food. So all these things need to be communicated with the patient. So lifestyle modification.
Yes, okay, sir. The second speaker is still, we have to hear the second speaker, sir.
Sure, sir. Please, go ahead.
Just a last remark, Dr. Khaitan. I think the word obesity should be removed from the dictionary of doctors. I don't believe, because as Dr. Madhukar very rightly said, it causes a huge stigma and we should not be calling it obesity. The other word that comes to mind is adiposity.
Definitely,
but again, I don't agree with the word adiposity, because that does not tell you exactly what is wrong. And the word exactly, the best word, which I think was coined by Dr. Shashank Joshi, and I liked it, is adiposopathy. Adiposopathy is the best word to be used when we are talking about this condition.
To make it less complicated, adiposity with metabolic consequences.
Right, absolutely, sir. Absolutely, sir.
So this one just final comment. This reminds me of like 18 years back when I was in UK during my MRCP exam, PACES exam.
Yeah.
One of the station was like a history taking like that. There was a obese lady sitting there. So I used to take, I need to take the history and present to the examiner. The examiner was so particular. He was holding the paper and the pen like this. And he was asking, okay, present doctor. So he was expecting me to tell obese, the word. So we were trained like that in such a way. This 32-year-old, you can't tell old also. This 32-year lady who has got high body mass index. What did you say, doctor? High body mass index. Okay, you can go. You are passed in the station. Because moment you say obese in front of the patient, you are gone.
The one last
That
comment.
reminds me.
One last comment is that with the GLP-1, you can have some cases of permanent gastroparesis and very uncommonly visual loss also. So that also has to be kept in mind.
Sir, if you allow me 1 minute.
Right.
Firstly, we have to convince ourselves that lifestyle modification is truly the cornerstone in our day-to-day practice. Whenever we enjoy a conference meal and Akash sir says, "Jha sir, you have not taken ice cream. It is very tasty. I have finished my quota of calories and do this." Secondly, as far as the exercise part is concerned, we are talking about insulin resistance. One aerobic exercise if person is doing, there is 40% increase in insulin resistance. And if you combine with the resistance exercise, it becomes 70%. So first we have to convince, only then we can have the impact on the patients. Why Baba Ramdev is having more better communication? Because he is convinced that yoga is the ultimate thing and he is putting it through. We are confused. Akash has said one line which was very important, that we physicians, we doctors are confused in ourselves. Are we able to restrict our calories? Are we able to control our behavioral pattern? Are we regular in exercise? That is why we are having the communication problem.
Absolutely right, Dr. Jha. I think you have hit the nail on the head.
I think
we'll move on to the second.
first session.
One last comment, sir. Any ignorant person is very confident, and any person who knows that he does not know will always have some degree of underconfidence.
Some degree of confusion.
So Baba
Doctors
Ramdev
are
is
the most
the ignorant person.
Doctors are the most ignorant lot. Who
Yeah.
know everything but do not practice. This is the biggest ignorance.
Right. I think
the session to be over and hence
सर एक कॉन्फ्रेंस में हमको याद है एपीआई के कॉन्फ्रेंस में एक तरफ जो है हेल्दी फूड था, एक तरफ जो है जो यूजुअल फूड होता है. नोबडी वेंट टू द हेल्दी फूड कंपार्टमेंट.
सर स्टेयर्स भी रहता है, लिफ्ट भी रहता है. How many people climb the stairs? Everybody uses the elevator.
Talk is so much interesting.
Dr. Bimani, second session start करें please.
Yeah. I think we'll start the second session.
Yes.
Thank you, Dr. Khaitan and Dr. Akash.
To Dr. K.K. Lohani for the second session.
Yeah.
Dr. Birmani, please start the second session.
Yeah. I'm starting the second session. Now, the topic is very interesting. Artificial intelligence in diabetes, pros and cons. AI has there, whether you love it or hate it, it has come and we have to accept it. To tell you how fast it is growing, let me give you a simple example. In 2023, when AI really hit the healthcare system, all the healthcare providers were afraid that AI will take their job away. That was 2023. 2024, healthcare providers were not afraid that AI will take their job, but they were afraid that AI will be doing something and they will not know what is happening. In 2025, healthcare providers are leading the AI revolution. They're leading the AI revolution. That is how fast we are growing in AI. You can imagine. And we have now two organizations. One is the Doctors AI led by Dr. Amit Dey and Dr. Kulkarni. The other one is the Doc-Centric, recently formed by Dr. Bharat Sabu and Alok Modi and all that. And they're doing a wonderful job. And we have to know. And as far as diabetes is concerned, all of us know the role of CGM. All of us have got a mobile phone. We know we are using smartphones. Everybody almost, even in villages, smartphones are available. And there is no way we can avoid artificial intelligence. Only thing is, we must understand that it is there as an ally, as a secretary. It is your secretary. It is not going to replace you. Ultimate decision has to be taken by the doctor. Nobody can replace your clinical decision making. Nobody can replace the human touch. Nobody can replace empathy and compassion. And with these few words, it's none other than my very good friend, Dr. Aravinda, to give the talk on this. and he's from Bangalore, and he's a very famous don of sandalwood. He's also a very handsome and very good actor and an excellent orator, very knowledgeable. So over to you, Arvindaji. Go ahead, please.
Thank you, sir. Thank you, sir. Thanks for the nice words. I'll share my slide.
Yeah, please go ahead.
Are you able to see my slide, sir?
Yes, sir.
So, good evening, everybody. At the outset, thank you for making me a part of this Ccdsi Cme. Dr. Lohani asked me to do this one session in one of the conference. I very eagerly agree to that because presenting my topic in front of all the doyens is a big honor to me. So I am the last batsman, I hope, for this particular year session, but I'll do the justice for this particular topic. Artificial intelligence in diabetes, pros and cons. So first of all, greetings to all of you from Bangalore. So AI hype versus clinical reality. So what is artificial intelligence? So artificial intelligence is when a computer mimics human intelligence to perform a given task. Example, medical diagnosis. Next comes the machine learning. You can see in the circle in the middle, you can see the machine learning. What is machine learning? It is a subset of AI that learns to perform given tasks from data and improves with experience. Next comes the deep learning. You can see there in the circle DL, that is, it's a subset of ML, that is machine learning, that uses large neural networks and big data to better solve complex problems. So this is the basic things which we should know. Artificial intelligence, machine learning and deep learning. These are the basic things which all of us should understand. So the types of artificial intelligence, you can see based on the capabilities, there is a narrow artificial intelligence, general AI and super AI. On the right hand side, you can see based on functionality, there is self-awareness AI, theory of mind, limited memory and reactive machines. So if you take the evolution of AI in healthcare, from the top right, you can see from 1950, that is when the development of the Turing test. In 1971, the research on computers in medicine. In 1975, first NIH-sponsored AIM workshop. Then in 2000, we saw deep learning was introduced. In 2007, deep QA technology. In 2010, that is CAD applied to endoscopy. That CAD is computer assisted diagnosis applied to endoscopy. In 2015, PharmaBot was developed. In 2017, first FDA approved cloud-based DL applications. In 2018-20, and still it is going on, there are so many AI trials in gastroenterology. Now the system has entered into diabetology. If you take AI tools in healthcare, one is the clinical practice, second one is the biomedical research, public health, and the health administration. The current uses of artificial intelligences in healthcare, if you see, first is the medical diagnosis, personalized treatment plans, drug discovery, robot assisted surgery, remote monitoring, which was very rampantly used during COVID times, and most important, which all of us are using nowadays, that is electronic health records. So the chronic health conditions considered to benefit from AI, one is the infectious disease, that is 46%, neurological disease 56%, cancer 63%, heart disease 63%, and diabetes, that is 66%. So how artificial intelligence plays a role in healthcare, you can see the pros and cons. So on the left-hand side, you can see the pros. That is the beneficial effect. What is that? It's the better data-driven decisions, increased disease diagnosis efficiency, treatment time cut in half, integration of information, reduce unnecessary hospital visits, and create time saving administrative duties. On the right hand side, you can see the cons. That is, there are the concerns regarding privacy and security, lack of curated healthcare data, high initial capital investment, lack of interoperability, reluctance from staff to embrace high AI, and potential for increased unemployment. So these are the pros and cons of AI. So if you take AI and diabetes, which is the next frontier, that is today's tool, tomorrow's trim. So if we take this article, this is a review article, that is artificial intelligence in diabetes management, advancement, opportunities and challenges. You can see the recent advancements in digital health technologies, especially AI, provide a significant opportunity to achieve better efficiency in diabetes care, which may diminish the increase in diabetes related healthcare expenditures. So, what are the challenges in traditional diabetes management? First one is shortage of specialists. The like a lack of endocrinologists or diabetologists results in inadequate patients care, limiting access to specialized treatment. The second one, poor medication adherence. Many patients struggles to maintain their treatment regimens, impacting their overall health and glycemic control. Third one is the inefficient resource distribution. Medical resources are unevenly spread, especially in rural areas, leading to poor glycemic control and health outcomes. So you can see here the various forms like AI-powered social media, AI-powered customer chatbots, personalized recommendation, AI-powered virtual assistants. Like example, we have Siri, then auto correction is there, ride share apps navigation, targeted advertising. So there are various platform where AI can be used, which we are almost indirectly we are using through our day-to-day life through mobile phones or through laptops or through computers. So the diabetes mellitus, if you take the key epochs are on the left-hand side, you can see the early discoveries and insulin era that is pre-1920s, that is dietary modification, starvation diets, and discovery of insulin in 1921 made it possible to manage glucose levels effectively. Next is the blood glucose monitoring, that is in 1960s to 80, that is the Benedict's reagent, home blood glucose monitoring, semi-quanta methods, precise measurements, and self-management. Next is the digital data management, that is 2000s to till present. If we take, there are insulin pumps, CGMS, real-time transmission, mobile apps, data analytics, actionable insights. Next, on the extreme right, you can see the AI ML, that is 2010 till 2025. You can see there is an integration of AI and ML into the diabetes management, prediction of glucose fluctuation, recommend insulin doses, unlock previous inaccessible insights. So now, why diabetes is important? Like you can see the rise in prevalence, great economic impact, and increasing demand capacity mismatch. Need for scalable solution, that is automated tools that make technology, complexity of diabetes, that is heterogeneity, multiple variables that predicts disease progression, complications and outcomes. Next is the need for precision and personalization, like no one size fits all approach. AI can aid in analyzing complex data, identify patterns, and predict individual response to treatment, leading to more effective management. So, CGM data provides a rich substrate for ML, for diagnostic, clinical decision support, and self management. So, the diabetes self management can place a heavy mental burden on the patient. The multitude of decisions throughout the day can overwhelm the patient. Then, like diabetes distress is there, abandonment of technology, and non adherence. These are the various aspects like in AI in diabetes. So, AI for predicting and diagnostics complications of diabetes. There are three aspects which we have to remember. One is for the screening and the prevention. In the middle, you can see the diagnosis and the prognosis. On the right hand side, you can see the treatment and management. These are the various potential applications where AI can be used in diabetes. So, AI in diabetes, what is the current state? Starting from the left-hand side, you can see the automated diabetic retinopathy screening. I'm sure many clinics have been implemented with this fundoscopy, where the machine detects the retinopathy by giving the image. This will be approved by the specialist, and then we can suggest the patient what further has to be done. Next one is the clinical decision support, patient self-management tools, and risk prediction and stratification. So the automated diabetic retinopathy screening, so you can see it fall under FDA class 2 medical devices. So software as a device. If you see this next line, you can see the IDX DR, that is IDX diabetic retinopathy. It's the first fully autonomous AI system across any field of medicine to receive FDA clearance. It has got a sensitivity of 87% and a specificity of 90.7%, stringent reference human grader. Next is the IART, the sensitivity of 95%, specificity of 85% for detecting more than mild diabetic retinopathy. Next is the AIDS. Automated systems are not appropriate for patients with history of laser treatment, prior surgery, intravitreal injection, pregnant patients, or patients with persistent vision loss, floaters, history of severe non-proliferative retinopathy, proliferative diabetic retinopathy, and retinal vein occlusion. So, retinopathy is the one field which is progress very well when it comes to AI. There are certain contraindications also, means that is not beneficial as shown in the last line, and most of the time 75 to 80% is beneficial, especially in the clinic settings where you may not have the ophthalmology colleague, but still we have to do the annual retinopathy screening. So this fundoscopy definitely helps with, which has got a good sensitivity and specificity. So you can see in this slide the artificial intelligence in diabetes care. The example of the output of the Meteor's artificial intelligence algorithm in an individual with a diagnosis of referable retinopathy. How the diabetic retinopathy detected, how the further referral to the ophthalmologist so that the appropriate measures is taken early and prevented the progression of diabetic retinopathy. So next is the diabetes clinical decision support. So there are many apps here, many applications are there. One is the Advisor Pro, is an FDA cleared insulin pump recommendation tool which was developed by Israel. Next is the analysis insulin pump, CGM, blood glucose data on the cloud to make suggestions for settings such as basal rate, carb ratio, diabetes management tips for the patient. The healthcare professional receives the report with recommendation and can be edited to share with the patient. So AI based adjustment was non-inferior to manual adjustment by a specialist. See, this is how the specificity and sensitivity is there. So next is the patient self-management tools, like how we advise to the patient certain things. Where if the nowadays in the era of smartphones, these things can be done as whether if the patient doesn't understand this, at least their family members, their children, grandchildren may be definitely help in patient self-management. There are several things like Guardian Connect tools. Then is the model for was trained on anonymous CGM data for more than 10,000 users representing 10 million patients hours. So by doing this, we can analyze the patient data, educate the patient how what best can be done. Next is the promise of autonomy, that is the Beta Bionics Island Pump. It is currently available. Semi-automated insulin delivery systems require individualized insulin regimens for the initialization of therapy and the meal doses based on the carb counting. In 2023, FDA approved for Beta Bionics Island Pump but dosing decision software for type 1 diabetes. Next is the fully integrated insulin delivery device that operates with a CGM. Initialized using the patient's body weight, no carb counting, corrections, or preset basal rate. autonomous adaptive lifelong learning algorithm for insulin dosing. So these are the parameters are there, but we should not hesitate. As a doctor, the tendency is there. We tend like, what is this, all these things, what AI, what I learn, what I will do with this thing. That comes into our mind. But just like how we adapted to the smartphone from the old Nokia phone, what we used to use like 25 years back, how we adapted to the modern Android phone or the Apple phone, how we are very happily using without any hesitation, without any discomfort. In the same way, the modern technology we need to adapt. Why this beta ionics islet pump is important? You can see in this slide, no carb counting, no correction, islet algorithms are there, no preset basal rate. So all these benefits are there. So we can't say that these things is expensive, whether the patient whether the patient understands it or not. Because just like how we are, patients are, how the people are taking Apple phone, Samsung phone, Android phones like that, where the cost is not a factor, it's always becomes our moral responsibility to tell to our patient these things are available in the market, whether you want to take, whether you want to use. You have to tell as a doctor from the horse's mouth. Other then only the patient see whether they can accept it or whether they can be educated, then it can be planned accordingly. So next comes the risk prediction and stratification. So the AI assisted prediction models pave the way for preemptive medicine, which involves steps to prevent disease before it occurs. So this is very important. There is reactive, proactive. There is a new paradigm. Next is the current statistical models for predicting type 1, type 2 diabetes risks are also quite good. So there are some machine learning model which helps in predicting the onset of diabetes. Next, we know the pre-diabetes to diabetes progression as well. So when there is a pre-diabetes and diabetes progression, there are some apps which can be used. All these are in the pipeline. I'm sure in the coming days, we need to learn about this. We need to use about this. We need to use these applications so that we can educate the patient. So if you do this diabetes progression can be postponed to another 2 years, 3 years. Like that, the educations can be done. So you can see there are some novel markers also. You can see in this slide, Avram et al. In 2020 reported a digital biomarker for diabetes using a deep neural network on smartphone-based photoplethysmography data. The data was obtained by placement of a finger on a smartphone camera and the Azumo iOS app. So simple finger, it was able to tell the digital biomarker of these things. Next is the vocal biomarker. The series vocal. A study used 6 to 10 seconds of people's voice along with age, sex, height, weight to create an AI model that can distinguish whether that individual has type 2 diabetes. So the model had an accuracy of 89% for women and 86% for men. It is unthinkable, which was unthinkable 10 years ago. Imagine just a vocal biomarker. You just talk for 6 to 10 seconds and we will be able to do. So all these things are in pipeline, which will definitely the future in diabetes management and diagnosis. Next comes the AI for diabetes remission. You can see the digital twin. What is digital twin? It is a virtual replica of a patient's health status by using ML to develop predictive modeling and personalized approaches to DM. A multi-center RCT by Twin Health compared DT, that is digital twin, versus the standard of care. So you can see Freestyle Libre CGM plus Fitbit watch to track activity and heart rate. I'm sure all of us are using this, especially the watch one, which is quite popular among our doctors, where everybody uses this during the conference also to track their activities. Next is the smart scale and BP monitor. Most important, clinical history and lab profile at the enrollment. Next is the whole body digital twin. Then the A1C change predictor. Then 72.7% digital twin participants achieved diabetes remission versus 0% in the standard of care group. So weight change, like digital twin had the 7.4 kg reduction versus 0.4 kg reduction in the standard of care. So this is how the things can be eased out by a simple technology where educating the patients about this particular health aspects, particular AI aspects, helps in reducing the remission as well to certain extent. You can see here digital twin is a, we can see the geolocation identified restaurants and menu with the estimated carbs. Next is the clue detects meal initiation, duration and quantity of meal. Next is the accelerometers and heart rate monitors identify amount and intensity of exercise. In fact, everything is monitored, like it can tell you how much did you eat, how much did you exercise, as our smartphones are doing already. Next is the large language model, that is LLM. In diabetes care, if you take, it can respond to free text queries without being specifically trained in the task in question, like Chat GPT, as we are using in our day-to-day practice since last 1 or 2 years, it has become more popular. So Chat GPT is a generative AI chatbot produced through fine-tuning of a large language model, personalized education, and on-demand interactive teaching production of an educational material. Next are the administrative tasks, especially the discharge summaries and letters can be performed with these large language models. Next, it's a promising tool, that is current LLM technology will be most effectively leveraged as a tool under close supervision rather than autonomously. So now the challenges and ethical considerations, which is very, very important in the present generation. That is the data privacy and security. Next is the bias and the representativeness in data. Next is the transparency and explainability and accessibility and equity in healthcare. So these are the main challenges for the AI where we have to be very careful, and recent guidelines are also coming regarding the use of AI in clinical practice. You can see in this article in a digital oncology where medical chatbots can offer relevant high quality information, reassurance, answers, and ways of thinking about the situation related to the human behavior. So there is the other important aspect is the insulin injection guidance. I'm sure all of us using this, where we explain to the patient tends to understand, and once again they tend to forget very easily. Because this particular AI app, if we can use, definitely it will improve the patient injection techniques, especially in type 1 diabetes. Even you can see the DCCT trial indicates that a 1.9% decrease in HbA1c could significantly decrease the risk of complications and death. So, by using this injection proper techniques, the HbA1c can be properly controlled. So you can see here in this phone how the things are changed. The Android smartphone, we can use the CGM transmitter, insulin pump, all these things are interlinked. Only thing, we should have some patience and time to interpret for the better care of our patients. Next, we have the CGM, that is the blood glucose monitoring, continuous glucose monitoring, employing an intelligent algorithm combined with insulin pump therapy can help patients achieve better understanding of their blood sugar fluctuation. In the US, you can see the WellDoc diabetes management system, a smartphone software application, has been approved by the FDA and is covered by most types of medical insurance. Doctors can use this system in conjunction with the patient's blood sugar diaries to provide individualized feedback and recommendation via real-time online communications. So monitoring of diabetic complication, very, very important aspect where the AI has played a role. You can see in this picture is that you can see the most common complication of diabetes like vascular pathologies and peripheral neuropathy. The scholars who assessed the adult retinal fundal photographs found that detection of diabetic retinopathies by a deep learning algorithm achieved sensitivity and specificity of more than 93%, as discussed earlier. A mobile app called Foot Snap was developed to standardize diabetic foot images. A Jacquard Similarity Index was used to confirm the reproducibility of foot images. physiologic and applied to the medical records of 244 patients diagnosed with diabetic neuropathies, they found that system could intelligently determine the severity of diabetic neuropathy with sensitivity of 89% and a specificity of 98% and an accuracy of 93%. So this is a blessing, because you can see the moment you see a diabetic food, you use this app and say these are the complication to is going to happen. So we treat them aggressively from the beginning so that the amputation also can be prevented. So next comes the needle-free revolution, smart insulin pens, artificial pancreas, automated closed loop system. This is all the new technology in the future diabetes care. So the global healthcare workforce shortage is imminent. So this always the talent is wanted. We all agree on that. So experts are pessimistic when it comes to human resources situations in healthcare. There are worrying tendencies about off balance of supply and demand of medical profession. According to the Medical Futurist Institute, the needs based shortage of healthcare workers globally is about 17.4 million. So this is one important aspect to be looked into. So the implementation of artificial intelligence is a true challenge. The question we always have to face is how we translate the vast potential of artificial intelligence into everyday life. After the very first step, getting to know the most possible about AI in healthcare, we should get clearer picture of the obstacles. So challenge we should accept. We should always say challenge is accepted and we should march ahead. So the medical community should not fall for the fear mongering around AI. This is very important. At the dawn of fourth industrial revolution, automation and digitization are turning the job market upside down. Many fear that robots, AI, and automation in general will take their jobs without alternative. Do you all agree? I don't agree. So artificial intelligence cannot replace empathy, as Dr. Veermani sir told in the beginning. So it cannot replace empathy. Even if the array of technologies will offer brilliant solution, it would be difficult for them to mimic empathy. Why? Because of the core of empathy, there is a process of building trust, listening to other person, paying attention to their needs, expressing the feel of compassion, and responding in a manner that the other person knows they were understood. This is what we are doing since many years now. So the changes of AI in the healthcare sector, the drawbacks of AI in healthcare sector, data collection and algorithm developing concern, social concern, ethical concern, and most important, clinical implementation concern. To be summarized with, we are witnessing the first innings of the transformative era in healthcare. Development of AI holds exciting promise for the fields of medicine. There is still a need for caution when using AI, especially in healthcare, that needs to be addressed before its use can be widely implemented. Over reliance on data, lack of regulation, SCP researcher and patient comprehension. Future direction could include more refined AI analysis, more individualized inputs and outputs, and new techniques of machine learning. So the pipeline of AI-driven products promises a future where care for diabetes is more effective and integrated and patient-centric. Then comes the revolutionizing of early detection, empowering self-management, enhancing clinical decision support for clinicians, comprehensive patient education, and most important, alleviating the burden. The future of AI in diabetes care is not just about technological advancement, it's about creating a more human, personalized, and empowering healthcare journey for millions of people living with diabetes. I'm sure we have all seen this robot. One movie had come, Entiran. Using AI tools meant to help, but obviously the robot lacked the emotion. See what happened. But if we rely on it too much and ignore the human aspect, it could be like this fellow Chitty putting the healthcare at risk. So we have to be very careful. Whatever the AI comes, the human touch is always needed. So combine with strong patient relationship and invest in digitalization of records, elderly friendly tech, and patient education. So use AI for what it does best: data crunching and pattern recognition. You can see in this how the chitti is there. So we have to use it very cleverly. So this should not happen, isn't it? Let's hope no future patient has to say. So this patient telling 2040 dying in the operating table because the doctor used chat GPT to pass medical schooling. Funny now, but let's make sure AI supports medical learning, not replaces it. So the computer may say, मेरे पास जेमिनी है, चैटबॉट चैट जीपीटी है, मिड जर्नी है, को पायलट है, अल्फा कोड है, सिंथेसी है, कंपोज एआई है, डाली टू है. The computer may say, the AI may say, the robot may say, but I will always say, मेरे पास पर्सनल टच है, empathy, sympathy, and experience है. So thank you for your patience hearing. So this is about the artificial in diabetes, pros and cons. Thanks for making me a part of this wonderfully organized CME. Thank you, sir. Over to the Arvind.
Thank you. Thank you, Arvinda, for an excellent talk. One of the best talks I've heard recently on AI. And I don't know, I'm really stunned the way you given the presentation. So beautiful and so nice. Now AI is really revolutionizing. The amount of data that we are handling today is impossible without AI helping us. The digital twin is the future of AI. Just to give you two examples, I'll give you. Dr. Akash gave a wonderful talk on GLP-1 RAs. Now, I must say that around 20 to 30% are non-responders. 50% are going to leave at the end of 1 year, 50% stop their drugs. Perhaps tomorrow we'll have a tool that will be able to tell us which patient is going to respond, which patient is going to leave, why give him this costly drug. There are patients who respond to sulfonylureas. There are patients who respond to metformin. We'll be able to know who is going to respond. So it will be precision diabetes that we're entering, the era of precision diabetes. And how AI is to be used, I'll give you a very, very simple example in layman's term. You are walking into a dark forest. And when you enter a dark forest, your eyes are not able to visualize anything. So what do? You take out a torch from your pocket and you shine a light. When you shine the light, that light shows you the path that you have to take. But it is not the torch that is seeing the path, it is your eyes that are seeing it. So AI is just like that. AI is just like that torch. It is showing you way, and it is you who are taking a decision. Similarly, there have been a lot of criticism regarding why doctors are using chat GPT and all that nonsense. But let me tell you one thing, that the chat GPT that we had 2 years back and the chat GPT we are having today is customized. Customized means books like Harrison's Medicine, the Williams Endocrinology can be uploaded to the chat GPT, and you will get answers, specific answers from those books. Number two, whenever you are using chat GPT or any AI generative tool, remember one thing, a prompt is very important. And what is a prompt? Prompt is the command that you give when you are asking for something. Suppose I give a prompt, I want to prepare a talk on GLP-1 RAs. Now, that is not sufficient. I must tell also add in the prompt, please look through PubMed Cochrane analysis.
Yeah.
And then give me the answer. Then it will give you the right answer.
Yeah.
So it is very important. You must be intelligent enough how to use it, because it is your secretary.
Yeah.
If you tell your secretary how to type a letter and just keep quiet and sign it blindly, you will be in trouble tomorrow.
Yeah,
You're going to see every letter. So these are my comments. And Aravinda, you are superb today. Any questions from the audience?
Dr. Virmani, I would like, outset, I would like to congratulate Dr. Arvinda for excellent presentation.
Thank you,
And
sir.
I agree with
Wonderful
him.
job.
I agree with him that this is the AI not going to replace, it is going to assist, as you have said also. But the
Absolutely,
most
sir.
important hesitancy is on our part. It
Yes,
is the
sir.
doctors. We are scared. We should not be
Yes.
scared.
Right, sir.
We should come forward and take it, because it is not the patient who are hesitant. It is a we.
Absolutely.
If we are convinced, I think the patient will be convinced.
Absolutely, sir. Absolutely. Sir, even in
Dr.
medical
Virmani,
science, things are changing daily. There was a time when beta blockers were contraindicated in heart failure, and today they are one of the pillars in the treatment of heart failure.
Yeah.
So you have to learn how to change. We have
Yeah.
to learn how to change. Yes. Somebody was saying something.
Dr. Virmani, एक चीज
Yes,
मैं
sir.
बोलूं.
Yes, sir. Yes, sir. Please, sir.
My contention is,
Yes, sir.
जैसे हमने calculator को computing abilities दिया, when
जी.
we gave this calculator, the only thing which we look is the outcome of the computation. We don't know what is going in between.
Yeah.
And if the system goes wrong, we take that for granted. The same is going to be happening with AI. You are talking of Cochrane or you are talking of other analysis. Do you think that those analyses are correct?
Still not correct, sir. Still many things are there.
So what is the question is that human mind, and another study shows that those who have started using AI, their brain function have started declining.
Correct, sir.
That's another aspect. If
Because
you
they are
delegate,
totally dependent. You don't have to be totally dependent.
that's what I'm saying. The day it is Dr. Virmani's wisdom, and it is something like that Einstein's wisdom that he withdrew away from the this nuclear bomb project, and the other day somebody dropped the bomb, and there was a devastation. So it's like who is the wise person to use this thing?
Sir, you must cross-check your references. I think you're gone mute. Dr. Madhukar Rai, you're not, something wrong
now
with
the
the
network. Now, yes, sir. Yes,
He
sir.
has got network problem.
Question is, this technology should always be assisting, and the person who is using technology should know ins and outs of technology, just like Dr. Arvinda. You should not be merely an end user, because you are dealing with human life. You are dealing with human, और भी बहुत सारे गम हैं जिंदगी में, and what is going to happen to the quality of life if you're all tangled up in data and other things. So it is going to help you assist it and try to get into the best mode which is possible.
Your voice is breaking. I think your network, you need AI to boost your network.
Yeah, I hope if it could do it. Anyway,
Sir,
it was very nice. It was wonderful presentation.
There is a saying today that if you are totally dependent on AI, remember, intelligence, that is artificial intelligence. But human stupidity is original, and that will come into forefront. So don't depend on it blindly.
Yeah.
Use it as a help.
It's Dr. Virmani's version, but the newcomers who are coming, they simply look at the printout and they take the decision.
That is the problem, sir. That is the problem.
How to fix that problem?
Sir,
they
have
lack
to
the
learn.
maturity.
They
Once
have to
time
learn.
will tell them.
They have to learn.
Yeah.
See, when we are reading an article which is published, what do? We read the title, we read the abstract, and we read the conclusion. Nobody bothers about methodology. Nobody knows what has gone wrong in that article, and then they start quoting the article.
Sir,
but when you go deep, you find this is a biased article. So many articles have been withdrawn from prestigious journals like New England Journal and Lancet, because when they went into methodology, they found the methodology was wrong. So these are
So
the things that we.
that's what I'm
I've
saying.
done-
Dr. Virmani
I've
can
done one
point it
experiment
out,
there
but
with
the
AI.
medical graduates who are coming out,
So they have
they-
to be taught in that way. We have to educate them, and that is why the doctors AI started a course, primer AI primer in all the medical colleges. In fact,
Very
when we
important.
were in Jabalpur for the for the Ccdsi conference, we had a talk in one of the medical colleges there, and Dr. Rai sir were also there, and it was a wonderful thing. We're teaching the medical students how to use it.
And Ccdsi is going to part of the AI conference at Bangalore, isn't it?
Yes, sir.
Yes, sir. Yes, sir.
November 12th, 13th
We have,
is
we have
only.
collaborated. We have collaborated with them.
Yeah.
AI with human intelligence is the super. If
Sir, it
minus
is.
human intelligence is the
Arvinda,
It is artificial will remain artificial. It is augmented intelligence that we are looking at. It is just augmenting our intelligence.
Sudhir sir,
I've
you
done
want
one
to tell
experiment,
things?
sir. 100
Yes, sir. Yes, sir. Yes, Dr.
100
Khaitan,
I
please.
put on the AI, and I think
Yes.
70% answers were wrong. When I hinted the AI, these is the things, then his answer was
Because the prompt was wrong. Prompt was not correct. If the prompt was correct, you will get 100% right.
Prompt is correct and the answer is correct.
No, sir. You have to give a detailed prompt. If you want a detailed answer, you have to give a detailed prompt. Suppose you want to get an ECG interpreted, you cannot interpret an ECG without a good clinical history. Unless you give a good clinical history, it will give you a wrong answer.
I've done the 100% with 100 cases, sir. Almost
Yes.
70% cases are wrong, in spite of all the good history and ECG as such.
Then you are using the regular chat GPT. Use a customized chat GPT which has been trained in ECG. So what is computer? Computer is a gigo, garbage in, garbage out. So unless you feed the right data, you're going to get the wrong data.
I have come to the conclusion that the AI plus human intelligence both work together. Then it's okay.
Dr. Jha wants to say something. Dr. Jha.
I
Yes, sir.
request Dr. Virmani to sum up, please.
No, Dr. Jha wants to say Lohani something.
Dr. Lohani, you want to have any comment? Or Dr. Jha wants to have a comment? Yeah, Dr. Jha?
Yes,
yeah.
I want to congratulate Arvinda on the outstanding presentation.
Thank you, sir.
We don't know much about AI, but you have been able to stimulate the great interest in the subject. Your presentation slides were also fantastic, particularly the last one, where you almost look like Rajnikant. And I'm sure you have used AI to the perfection. And that is why in your Facebook comments, many of your followers say, Thalaiva.
I already told you, Dr. Jha, he is the Don.
Rajnikant.
Dr. Jha, I already told you he is the Don of Sandalwood.
Yeah,
so you can understand.
Thank you, sir.
And I think, sir, I'm also discussed with Dr. Rai, sir, that we'll have a workshop for all the Ccdsi members on AI. We'll plan a workshop. It will be about 4 to 5 hours workshop we'll plan, so that at least all our members are aware of what is happening in the near future. And I said digital twin is the real revolution, is the future of the whole, the way we are going to treat our patients. From a reactive approach, we are going to a proactive approach. And that is what the Dr. Arvinda also very rightly stressed. So I think I'll end this session here and hand over to Dr. Lohani, please.
Thank you, sir.
Thank you, Dr. Virmani. And thank you, Dr. Arvinda, for excellent talk and excellent chairing the session. Well, dear colleagues, all of you will agree with me that the idea of having a CME on obesity and AI has been very successful. And many people ask me, suddenly, how did you decide to keep these two topics? And let me share the reason with all of you. Our Prime Minister is talking about AI for 2 years, and from this year, he has started talking about obesity. So this is the high time we should know and we should discuss it properly in our forum. We are already late, so there's a agenda that expert comment from Dr. Professor A.N. Rai. So, sir, if you want to say something or everything is covered.
Sir, you are muted, sir. Sir, you are muted.
Already discussed. Nothing much to add. Thank you.
Thank you, sir.
Dr. Mrityunjay is not around, if I know correctly.
Yes, he is ill.
So I
You tell-
request Dr. Abhishek, our Joint Secretary and Coordinator, to propose a vote of thanks.
Thank you, sir. Really, that was the excellent CME, as the tradition has been set in last 12-13 months. And I must thank both the speaker, Dr. Akash Singh sir and Dr. Arvinda Jagdisha sir, for their excellent talk. Practically, I have learned many things new. And as we know that in cardiometabolic sector, obesity is the leading disease. And likewise, AI is also leading at many fronts. So thank you, sir, for excellent talk. And necessarily this your talk will be kept in our e-library, and we will upload it on the website of CCDSI. I thank the chairperson, sir, Dr. DP Khaitan, sir, and chairperson for second talk, come Dean ICCMD, Dr. Anil Verwani, sir, for excellent conduction of this session. I thank our founder president, Professor A.N. Rai, sir, President Dr. Madhukar Rai, sir, and scientific committee chairman, Professor K.K. Lohani, sir, for guiding through all these processes. I must thank the senior members of CCDSI, Dr. S.C. Jha, sir, Dr. B.K. Singh, sir, Dr. R.K. Modi, sir, and many other delegates who have attended this CME both through the Zoom meeting and the webinar webcast. I thank all of you, all of my colleagues. Thank you, sir.
Thank you.
Thank you, Abhishek. And I must thank from my side to Dr. Akash Singh and Dr. Arvind for accepting my request. On the very first request, they agreed to deliver these beautiful talks. So that is the spirit. Thank you from the core of my heart. And
Thank you,
special
sir.
thanks to
Pleasure
Dr.
was-
Virmani and Dr. Khaitan, and obviously our founder president, Dr. A.N. Rai, and President Dr. Madhukar Rai. So I hope it was a very successful CMA. Thank you and good night.
Thank you. Good night.
Good
Take
night.
care.
Good night. Good night.
Bye bye. Bye bye.
Good night. Bye.